Right, well, I think we will kick off. Welcome, everyone. My name is Dr. Carmel Crock. I'd like to welcome you warmly to the ANZA-SIDM VMIA webinar today on the 3rd of May. Just to let you know, we are recording this webinar. So my position is I'm chair of the Australasian College for Emergency Medicine Quality and Patient Safety Committee, and I'm board chair of ANZA-SIDM, the Australian New Zealand affiliate of the Society to Improve Diagnosis in Medicine. And my clinical role is as an ED director at the Royal Victorian Eye and Ear Hospital in Melbourne, one of Victoria's specialty emergency departments. I'm really delighted to welcome you all this morning to listen to two speakers, Lachlan Crowe and David Newman-Toker. I wanted to start with just a little bit of background about the webinar and why we're holding it today. So the webinar is a follow-up from last week's Improving Diagnosis conference, which was held virtually and with the theme Embracing Challenges and Change. And VMIA was the major sponsor of this conference. It's our third Australasian conference on diagnosis, where we bring together thought leaders, the latest research, patients, clinicians, to advance the field of diagnostic quality, safety, and excellence. And after each conference, VMIA, as the major sponsor, has brought about a webinar which helps inform work that we do around preventing harm. And some of the work that has come from the conference is harm prevention in ED. So the purpose really of the webinar is to bring together some of the ideas from the conference and again, thought leaders. Now, again, as a background, we're talking today about clinical decision-making in the emergency department. And as you'd all be aware, the emergency department is a really challenging environment where assessment and treatment of a patient often proceed concurrently. Clinical decision-making is difficult. We're often caring for multiple patients at the one time. There's overcrowding, undifferentiated illness, trainees being taught, and both the college, the Australasian College for Emergency Medicine, ANZA-SIDM and VMIA are all dedicated to looking at how we can improve clinical decision-making in this environment and how we can prevent harm. I'm just going to admit somebody there that was in the waiting room, and I'm just going to try and advance my slide, which has just frozen temporarily. So I'm just going to stop screen sharing and I will resume screen sharing. Apologies just for a moment there. One of the works which has really informed our thinking in the last 5 or 6 years is this landmark report on decision-making and on improving diagnosis. And the report stated that improving the diagnostic process is not only possible, but it represents a moral, professional, and public health imperative. And one of the main outcomes of the report was to describe diagnosis not as a label that we place on a patient, but as a process with this visual representation. It's a process which evolves over time. So you see at the bottom there, the time line, and we gather information, we review the information, and we come up not with a definitive diagnosis, but with a working diagnosis. So a lot of the work in the last few years has been around changing the conversations about how we look at diagnosis. The report also describes diagnosis as occurring in a work system. So diagnosis occurs in a work system, and we can actually design the system for safer diagnosis. Failures occur everywhere in the diagnostic process, and each part of the process can be analysed and looked at for improvement. And the final real thing that I wanted to highlight from this report was that diagnosis we no longer look at as an individual pursuit, but as a team pursuit with multiple diagnostic team members. This is certainly true not only in the emergency department, but everywhere, with the patient at the centre of the team and all other clinicians, family members, radiology, pathology, part of the diagnostic team. So these have been some of the big changes about how we look at clinical decision making. And I would now like to hand over to Lachlan Crowe for him to speak to us about the harm prevention in the emergency department report and work that we've been doing. Now, Lachlan is an experienced improvement and healthcare professional. He leads VMIA's acute care harm prevention program of work, supporting health services and clinicians to improve outcomes and prevent avoidable patient harm. Thanks very much, Lachlan. Over to you.
Thank you, Carmel. And I'll just share my screen. That should be coming through now. Okay, well, thank you, Carmel, and thank you also very much to everyone for joining this webinar, particularly to those of you who've been involved with the project already. As I begin, I'd like to acknowledge the traditional owners of the land on which I am, the Wurundjeri people of the Kulin Nation, and I extend that acknowledgement to the traditional custodians of the lands on which you are all joining us today, and I pay my respects to their elders past, present and emerging. For those of you unfamiliar with VMIA, we're part of the Victorian public sector and we cover over 4,500 clients right across Victoria. This includes cultural institutions, major infrastructure, public schools, emergency services and our public health services. With our position as both insurer and risk advisor, our role is to work with our clients in the sector to improve patient safety and outcomes by helping to understand and manage the issues that lead to avoidable patient harm and claims. We've worked collaboratively with the health sector to deliver initiatives including prompt and incentivising better patient safety in the maternity space, safe wards in mental health. We're working on a perioperative harm prevention program and also beginning a psychological harm prevention initiative. And the one that you'll hear more about today is our Preventing Patient Harm in Emergency and Urgent Care project. So we know that in OECD countries, adverse events account for 15% of hospital expenditure, and a figure that's backed by research here in Victoria also. We also know that 10% of inpatients are affected by an adverse patient safety event, and that half of these are considered avoidable. So while all those adverse events don't lead to claims, they do give us an indication of where patient harm is occurring and where we can focus our attention. The impact of each of these events, even though they might be small in number, on the patients, families and carers and clinicians involved can be significant. In terms of those adverse patient safety events that lead to claims, our data shows that the greatest risk to a patient's safety is in obstetrics, perioperative care and emergency medicine. These are the areas where we receive the highest numbers of claims and overall costs, and that's consistent with the experience of other insurers globally. But we also recognise that clinicians are working in extremely complex and fast-paced environments, as Carmel spoke about, with competing demands, significant and high acuity caseloads, and of course, a raft of new challenges and pressures associated with the pandemic. And that's all of those factors are really the impetus for VMIA's involvement and for our current work. So our project, we understand that emergency departments and urgent care centres can be high-risk settings, and we want to support Victorian Public Health Services to prevent patient harm. So we partnered with Safer Care Victoria and the Australasian College for Emergency Medicine to deliver this work, to understand the issues leading to patient harm in EDs and urgent care centres, and to connect our health services with the right solutions. We've done this by analysing statewide adverse patient safety event data to understand the issues. And this involved deep dive into sentinel events reported to Safer Care, as well as VMIA's medical indemnity claims. We also reviewed incident and near-miss data from ASIM's Emergency Medical Events Register. We've completed a literature review and sector scan to identify the evidence-based interventions that might be appropriate for the Victorian context. And we've tested and interrogated our findings right along the way with the health sector to really validate what we observed and make sure that this reflected the experience and expertise of clinicians to be able to prioritise these findings into recommendations. And that's included through focus groups and consultation, working with Safe Care Victoria's Emergency Care Clinical Network, Ambulance Victoria, ASIM, as I mentioned, SENA, the Nursing College, and consumers, as well as significant input and guidance from our expert steering committee. So to our committee, and I'd just like to offer sincere thanks. We've had amazing support from the steering committee, and I would like to thank you all for your contributions throughout this project. We greatly appreciate it, and it's been critical to our work. I'd also like to acknowledge and thank the many others who contributed through focus groups, additional meetings and consultation from stakeholders right across the sector for sharing your expertise and your understanding of work as done as opposed to work as imagined, so that we can deliver recommendations and initiatives that will work in the Victorian context and address issues that are issues for you. So just briefly to look at some of the data from our project, and this is quite a high level view. This slide shows the contributing risk factors to closed medical indemnity claims since 2012 that have been coded to our classification system at VMIA. The majority of events involved misdiagnosis, failing to or delaying diagnosis, or a failure to respond to a deteriorating patient. That relates to management and treatment. When we looked at our claims, 2/3 of these within our data snapshot were by people who presented to an ED or urgent care centre with abdominal pain, neurological complaints, non-traumatic musculoskeletal or back pain, and minor injuries. When we looked at the most severe harms, these patients were diagnosed with severe sepsis and infections, cardiac and vascular events, as well as strokes, intracranial injuries, and spinal pathologies. And that really links with what we're going to talk about later today. So through our project, we've developed 11 recommendations that have been endorsed by Safe Care Victoria, the Australasian College for Emergency Medicine, and the College of Emergency Nursing Australasia. These recommendations fit within 4 main areas. The first being supporting clinical decision-making. The second, making information available to clinicians. The third, using system-level knowledge to make better use of resources. And the final being supporting learning and sharing of information about adverse patient safety events. We're now working with our partners to plan out the program of work involved and to begin delivery. These recommendations and our full project reports will be published on VMIA's website in the coming weeks. We'll send a link to the page once it's live so that you can access this online and view the full reports. So our first recommendation is about clinical decision-making support. And again, this links really closely with David Newman-Toker's work and research. It's to design and adopt new bundles of care for high-risk presentations to help clinicians rapidly assess a patient, choose the appropriate clinical pathway, and provide follow-up care after discharge. We're planning to develop bundles in the first instance for neurological presentations and for back pain presentations, based on the inputs and feedback during our project workshops. We'll be drawing on the subject matter expertise of yourselves as clinicians from across the sector to develop these bundles and working closely with our partners. As I mentioned, our full reports and recommendations will be available online, and we'll send through a link so that you can view those. Thank you all for joining. We look forward to staying in touch as we begin the delivery of our recommendations, and I look forward to hearing more from David about his work in the space. So I'll hand now back to Carmel.
Thanks very much, Lachlan, for an excellent summary of that work. We thought we'd leave the Q&A until after David's talk. So it's now my enormous pleasure to introduce David Newman-Toker from the United States. I'll just read a very short bio. So David is Professor of Neurology, Ophthalmology and Otolaryngology. He holds joint appointments in emergency medicine and health science informatics at the Johns Hopkins University School of Medicine, as well as in epidemiology and health policy and management at the Johns Hopkins Bloomberg School of Public Health. His research focuses on preventing missed strokes in the emergency department and primary care, especially among patients presenting with acute severe vertigo and dizziness. I'll pass over to you, David. I'll leave it there. I'm sure I could say much more about you, but I pass over to you as an esteemed colleague and friend. Thanks, David.
Thanks so much, Carmel. I really appreciate the invitation, and thank you to the VMIA team for all that you do to improve diagnosis in Australia and around the world. I'll just quickly make sure that you can see my screen. Are you able to see the full slide view?
We can now, yes, that's great.
Okay, great. So I've called this talk Neurologic Misdiagnosis in the Emergency Department, Transforming Diagnosis Through Technology-Enhanced Teamwork via Telemedicine. And that's a lot of T's. We'll talk a little bit about what those components mean as we go forward. I'm going to spend about 20 minutes, hopefully giving us plenty of time for questions and answers as we go. These are my disclosures, including various grant support from federal agencies and foundations, some research devices and grants from companies that I have no other financial interest in other than some Johns Hopkins technology for decision support that I do not own, but that has been licensed by the university to one of the companies. Obviously, my related roles in the past and currently related to diagnosis. And I will be mentioning the investigational off-label use of video-oculography to diagnose stroke. There's never time at the end to thank people. There are obviously an enormous number of people to thank for all of this work, not only our funders, but an enormous list of mentors, trainees, and collaborators that have assisted with this work over the years. And I'm just very grateful to have so many wonderful colleagues to work with here. These are some of our members of our Center for Diagnostic Excellence team here at Johns Hopkins. I'd like to particularly draw your attention in the highlighted rectangle there to Shervin Bedihian, our current fellow who's graduating and going on to neurology residency this summer. He was really instrumental in some of the key work that I'll be presenting to you tonight. In addition to the other fellow over on the purple bow tie on the other side, Dan Gold, who runs our TELE-DIZZY consultation service on the left-hand side. I'll start with what I'll call the base case, and this is really an opportunity to connect this to a clinical reality around a patient story. John Michael Knight, a real patient, an 18-year-old star lacrosse player who he and his family have given me permission to tell his story around the world in the hopes that what happened to him will never happen to anyone else again in the future. He was a star lacrosse player. He developed vertigo, vomiting, and unsteady walking. After his final high school game, he went to the emergency department. And the doctors seemed fixated on the idea that he must be taking drugs, which I suppose is something that 18-year-olds tend to do. But they really weren't listening to what his parents were saying. His parents were saying, look, this is a kid who doesn't do drugs. There's something wrong with him. We don't understand. His body's a temple. He's a highly trained athlete. He's like a Navy SEAL. And there really wasn't a sense that they were committed to the idea of listening to what the parents were saying. But even worse, they didn't know what to look for or how to look for it. And unfortunately, what was happening to him, these are not his scans, but they're similar to what his scans did look like, was that he damaged a blood vessel as part of his lacrosse game, his vertebral artery in the back of his neck. He had a progressive basilar occlusion, essentially an ischemic stroke syndrome in the back part of the brain that left him with a very large stroke in his brainstem. And unfortunately, he went from being an aspiring Division I lacrosse player on a full athletic and academic scholarship to really struggling to keep his day-to-day existence as somebody who's now quadriplegic and mute. He's painstakingly recovered to the point where he can tip his head enough that he can operate a motorized wheelchair. And he continues to strive to try to hope to recover bits of function that will allow him to be more fully engaged in his world. But this is an incredible challenge. He basically has to communicate with people by blinking his eyelids or moving his eyes using a communication board. So this is obviously a tragedy for him, for his family, and for the healthcare system, everyone involved. There's no good side to this. So your learning objectives, should you choose to accept them, are 1, to summarize the public health burden and financial impact of diagnostic error and misdiagnosis-related harms. 2, list common neurologic causes and prioritize targets for diagnostic error reduction and quality improvement initiatives. And 3, discuss how remote consultation programs can immediately contribute to diagnostic excellence. I'm going to break this up. I'll talk briefly about the burden and impact of misdiagnosis, then I'll specifically hone in on neurologic misdiagnosis, talk briefly about root causes, and then move into a section about system solutions where we'll focus in on the telemedicine type solutions. And then we'll summarize with some takeaways and have time for question and answer in the panel. So the burden and impact of diagnostic error, obviously you've heard from a risk insurance standpoint, this is the leading cause of problems. Carmel alluded to earlier the National Academy of Medicine's report on improving diagnosis in healthcare, which I think she quoted the single most important quote from the book, which is shown at the bottom of the page there, but there are 2 others that are important. The first is the delivery of healthcare has proceeded for decades with a blind spot, diagnostic errors. So it's something we haven't really been paying as much attention to as we should have, even though risk carriers have known that this was an issue. I think clinically we've sort of assumed that this was the price of doing business. And second, most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. And I think John Michael Knight is a sort of a classic example of what devastating consequences means. And obviously that's a huge tragedy, and we don't want that to happen to anybody, never mind to large numbers of people. And I think this critical quote, which I'll repeat just because it's so powerful, improving the diagnostic process is not only possible, but it also represents a moral, professional, and public health imperative. That's strong language, and I think it's justified in this case. And it's something that we all need to take to heart. We all need to own this. We can't just say, look, this is the way medicine works. Life is difficult. We're doing our best, give us a break. We have to say, how can we do better? And when we look at diagnostic errors compared to all other errors combined, as far as we can tell, diagnostic errors really dwarf everything else. Every time we look, the problem seems to be bigger. The more we measure it, the more we find. There are more than 12 million diagnostic errors each year in primary care alone, but some of our estimates suggest it's probably 5 times that number in the United States. Serious harms, we've estimated they're between $500,000 and $1 million at a cost of over $100 billion with a B dollars, US dollars a year. So this is enormous public health problem. It's the most common, most catastrophic, and most costly of medical errors. And it really is the bottom of the iceberg of patient safety and quality. So it's very easy in this context to get completely lost because diagnostic errors happen in every clinical setting, for every disease, under every possible circumstance. And one can get overwhelmed very quickly. But one of the things that I think is crucial is that it turns out that this idea of sort of don't miss health conditions that may result in patient harm tends to narrow down the list. The National Academy of Medicine suggested that we might focus on that as one of the possible ways to kind of focus our efforts. And when we look at what I've called the big 3, vascular events, infections, and cancers, these tend to account for a disproportionate fraction of all the serious harms from diagnostic error. So if you count these 3 big buckets, they account for about 75% of serious harms, not just in malpractice claims, but also in clinical case series. And if you look at just the 5 most common diseases found in each of these 3 buckets, what I'll call the top 15, they account for about half of all the serious harms. When I say serious harms, I mean permanent disability equivalent to the loss of 1 limb or worse, or death. And these are the usual suspects in many respects. For emergency medicine, it's the vascular events and infections that are disproportionately the ones under consideration. In primary care, cancers are one of the dominant kind of themes, but for the purposes tonight, we'll focus on the first two. And what I'll point out is that the overall error rate on these illnesses is probably somewhere on the order of magnitude of 10%, but with a very wide range from about 1.5% for myocardial infarction up to about 60% for spinal abscesses. And likewise, there's about a 4% serious harm rate in total, but again, highly variable by condition. And this is one of the themes that I think we have to grapple with as we tackle this problem at a public health level, is that there are no one-size-fits-all solutions. There are no simple, quick fixes that will solve every problem. And what we have to do is focus our attention on the places where we're missing opportunities to save patients' lives or prevent serious disability. All right, when I hearken back to the first case, the case of John Michael Knight, or what I'll call, put a little base case update in the top left corner, you'll see there. So when we think about the burden and impact specifically related to stroke, stroke is the #1 harm in the ED, the #1 vascular harm across settings. We miss it about 10 times more often than we miss heart attacks. There are more than 100,000 missed strokes per year in the United States. And the risks rise precipitously with what are sometimes called atypical cases, although we might rightly say that these are typical atypical cases, in the sense that it's the same things that happen over and over again. They are atypical in the sense that they're uncommon presentations of stroke, yet we kind of know what these pitfalls are. And if only we could construct systems of care that allow us to prevent those pitfalls from happening, we could actually close some of these loops. In particular, patients with milder, more transient, or more nonspecific symptoms are much more likely to be misdiagnosed. And the chief risk factor for missing a stroke is dizziness or vertigo. Compared to patients who present with weakness on one side of the body, we miss it 14-fold more often. So it's a huge difference. We don't miss strokes when people present in textbook fashion of weak on one side and unable to talk. We miss it when it looks like something else, like inner ear disease, which produces the vast majority of dizziness and vertigo of this sort. Here's an epidemiologic look that, and I'll walk you through the slide in just a moment, but basically this slide simply articulates that John Michael Knight is not alone. Okay? We can measure at a population health level that what happened to John Michael Knight is not some rare, weird event that's unmeasurable, that happens once in a lifetime. This is each year in the United States on the left. It's from 9 states around the nation. There were, in the year 2009, about 190,000 stroke admissions in those 9 states. And what you can see, looking back from everybody having been hospitalized with stroke to the prior 30 days, to both a set of suspicious symptoms, dizziness and headache, and a set of control symptoms, abdominal and back pain, that there's something sort of rotten in Denmark as you get to that week or so before the stroke hospitalizations. These are treat and release discharges for symptoms of dizziness and headache. And it's very hard to explain that other than to say, something is odd about dizziness and headache presentations such that they are unusually enriched in the days and weeks prior to the stroke hospitalization. Likewise, the flip side of the coin, when you look forward from dizziness discharges, on the top line, the solid line, shows stroke returns, which are elevated for a period of a few weeks afterwards and then return to a stable base rate, whereas the dotted line shows heart attacks, this from work by Anthony Kim and Clay Johnston's group at UCSF. And what you can see there is there's this period of elevated risk that represents some kind of short-term elevated risk. And it turns out that that risk window is the exact same risk window that we see major stroke after minor stroke and TIA. And so this corresponds to a biologically plausible relationship between initial minor or lesser stroke symptoms and ultimately significant enough stroke symptoms that bring you back for a hospitalization. This tells us that epidemiologically, this is a measurable phenomenon. And we've estimated that this translates to about 45,000 to 75,000 missed and 15,000 to 25,000 harmed in the United States. disproportionately women and minorities who are at 20 to 30% higher risk of an adverse event, as is the case in almost every area of patient safety. And in particular, younger patients aged 18 to 44, like John Michael Knight, are about 7 times more likely to be misdiagnosed if they have a stroke than their over 75-year-old counterparts. Now, they're less likely to have a stroke than an older patient, but if they do have a stroke, like John Michael Knight, their chances of being missed are exponentially higher. And you can see what happened to John Michael Knight is that he had the double whammy of having dizziness and being young. And that combination was almost a fait accompli that he was not going to be correctly diagnosed. It was the context is such that people are so tightly hooked to kind of the typical presentations and the high prevalence stroke situations that one is not one that was likely to be recognized, even though he could have been correctly diagnosed. And had he been correctly diagnosed, he would probably be playing Division I lacrosse now if he'd been given the appropriate thrombolytic therapy, since he arrived in the emergency department in the appropriate treatment time window. All right, let's shift specifically to neurologic emergencies sort of more broadly. And I want to just stop to take a question to say, what are neurologic emergencies? So it's very easy in emergency medicine to think of neurologic emergencies as acute spinal cord trauma and patients with subarachnoid hemorrhage who need urgent neurosurgery. And this is what I wrote an editorial or brief viewpoint piece with J.J. Perry from Canada in emergency medicine about. This is what we called emergency medicine neurocritical care. These are obviously sick patients who have neurologic emergencies, but the question is not a diagnostic one. It's really a therapeutic one. By contrast, there's sort of another subset of patients that we call the sort of acute diagnostic neurology kind of neurologic emergencies. These are situations where the patients are not obviously sick, do not necessarily obviously have some dangerous underlying condition, may be able to wait minutes or hours, or even in some cases days, for their treatments. But if time runs out, something horrible may happen to them such that they become one of these EM neurocritical care cases. And this is really where the rubber meets the road in terms of acute diagnosis of neurologic conditions in the ED. It's in identifying these subtly neurologically evolving cases and getting to them before things get so bad that it's too far gone to recover the situation. When we think about what neuro means from an emergency department chief complaint standpoint, if you actually add up all of the chief complaints that from an overall perspective fall under the heading of sort of neurologic symptoms, if you will, one could easily cast more than 20% of all ED visits as being linked in some way, shape, or form to a neurologic symptom that could be due to a neurologic disease. Certainly, not all of these conditions are due to neurologic diseases, because only about 10 roughly percent of ED cases are ultimately attributed to neurologic disease. But you can see that you have to go through the same decision logic at the bedside for all of these cases. And that's 1 in 5 patients. When we think about this from the disease perspective, and we look at malpractice claims and incident reports, this from an in-press report that you'll see coming out later this summer, hopefully, stroke is the leading thing at the top, as I alluded to before, but meningitis and encephalitis and spinal and intracranial abscesses tend to make the list as well, despite being much rarer diseases. And that's because we miss them with at very high frequencies. So one of the interesting things about this list is that it's kind of a mixture of cases that are relatively common diseases that we miss with moderate frequency, and ones that are relatively rare diseases that we miss all the time when they do occur. And this is the relationship between the approximate annual disease incidence in the US and the false negative rate, such as we've estimated in this upcoming report. And you can see, as you would expect, there's sort of an inverse relationship between the prevalence of the disease and our likelihood of missing it. But with myocardial infarction being kind of a notable low outlier. And I do think that we should be thinking in our heads, what is it that we're doing right with myocardial infarction that we could copy and do right for some of these other diseases as we go forward? I want to bring us back to the base case of John Michael Knight and talk about diagnostic errors in inner ear disease. It's not just strokes that we miss in these patients. We actually miss all of the benign inner ear diseases too. For more than 30 years, we've had level 1 randomized trial evidence for the diagnosis and treatment of what the disease called benign positional vertigo, little rock crystals in the ear that can be treated at the bedside and patients can be cured. Yet only 25% of emergency providers say they've been taught it, 11% say they do it, and fewer than 5% document it. And patients who are diagnosed with this disease or the other common peripheral vestibular disorder that looks like stroke, vestibular neuritis, are imaged with the same frequency as all other dizzy patients. So we're not correctly stratifying who needs to be imaged. The nystagmus description, the eye movement, abnormal eye movement description is documented, is inconsistent with the final diagnosis rendered in about 80% of cases. And I'll show you data in a moment that suggests that this in fact is the most, this number, which I wasn't sure was going to stand the test of time, is probably actually quite accurate. And nearly 60% of initially so-called benign peripheral diagnoses are wrong, and 37% turn out to be central disorders such as stroke, and 2/3 of peripheral diseases are misdiagnosed. So this is an enormous number, and I've tried to put this in both US terms and Australian terms, just so you can kind of put some of your own context on this. The total ED visits per year in the US are 130 million and about 8.8 million in Australia. And I won't read through every line, but basically in Australia, each year, there are probably more than 100,000 misdiagnosed dizzy cases in the ED. Half of those are benign positional vertigo cases that are misdiagnosed. And there are thousands of patients whose strokes that presented with dizziness, they're dizzy strokes that were missed, and probably at least a couple of thousand of those patients suffer serious harms, a la John Michael Knight, as a consequence. So it's a non-trivial number of people and something that we should all want to fix. Now, I don't have time to get into details around root causes, but suffice to say that when this has been looked at in any detail, we always end up, although the categories end up being a little bit different, the bottom line is that sort of the bedside decision-making is where things end up revolving for most of these conditions, most of the time. Sometimes it's called clinical judgment, sometimes it's called bedside history and physical, but it amounts to roughly the same thing. And these cognitive errors are sometimes thought of in the framework of a cognitive bias, but I think increasingly a lot of people in the field who study this issue have focused on the idea that maybe this is a function of gaps in expertise. And that's important because the kinds of solutions you might bring to bear in that context are probably different than if you felt that the majority of the problems were cognitive bias, where you might think about debiasing or timeouts. Here, you have to find ways to supplement the expertise that's available to people at the point of care. Just bringing this back to the base case from an old study that we did many years ago, 10-question true-false quiz on the bedside evaluation of dizzy patients with regard to differentiated inner ear disease from stroke patients. And the histograms shown are the results of those true-false quizzes for 28 emergency physicians and primary care providers. The curve shown is approximately normal distribution that you'd expect by guessing alone. And what this tells you is something very interesting, because the actual performance was statistically significantly worse than you'd predict by chance based on flipping a coin. So it wasn't that these were people who were uninformed, it's that they were misinformed. They were operating with misconceptions and they were faithfully reproducing those. So they had been taught the answers to these questions. Those answers were just wrong. And unfortunately, we found the same misconceptions found broadly in textbooks and in the medical literature. This is part of the problem, is that our entire educational system, which is built around sort of an apprenticeship model, tends to take decades for new information and innovation to percolate through the system. It's very difficult. So how can we bring system solutions to bear on this problem? I don't have time to talk about all of what I've called the 4 T's in the past, but I will focus on the teamwork aspect, in particular, this idea of engaging experts, or what we might call phone a friend. And we have a program, the phone a friend program, that we call TELE-DIZZY, just so that people can remember what it is that they're calling. It's not any old neurology consult, it's a specific kind of specific vestibular neurology consultation. And what it does is leverages some work that we've done over the years, and I, again, won't get into the details, but looking carefully at people's eye movements, experts can differentiate strokes from inner ear disease just by looking at a few key signs at the bedside. And we've now shown that you can do the same remotely by recording those eye movements. And then what you end up with are clinical findings that differentiate strokes, as in the bottom left panel there, where the vestibulo-ocular reflex is shown to be intact, from the one on the bottom right, where it's shown the reflex is impaired, but there's no stroke. Those situations are ones that we can diagnose remotely. Here's an example of kind of a view of what a specialist might see if we recorded the eye movements. In the bottom right-hand corner, you'll see a live video camera feed of what's going on in the room. So we sort of, it's as if we were there, we sort of have a perspective. Then we also can see the eye movement, and I'll play it for you in a moment, you'll see it moving. And then there are a bunch of squiggly lines that basically, think of them like an EKG. You know, they mean something to somebody who's been trained to interpret an EKG. And what they're showing us are the movement of the eyes, and what you can see is as the eye beats, it's sort of beating like this, a little bit upward. We see little jagged, zigzaggy lines that look like a sawtooth pattern. And this happens this is called nystagmus. It happens at a certain velocity, and then it peaks, and then it crescendos, and then it decrescendos, and then it ends. And to an otoneurologist who sees this all the time, this is benign paroxysmal positional vertigo of the posterior canal. We tell the person to roll the patient over 270 degrees, and they're cured, and they're sent home. So this is so typical that we can just literally treat the patient on the spot. It takes just a matter of a few hundred milliseconds. And this is a clear diagnosis. But this isn't always so simple. In fact, here's a case where a patient has a superficially similar eye movement, with the eye beating upwards and with a little bit of rotation. But this is one where it doesn't have that crescendo decrescendo pattern. And this is a patient who had a stroke. So this is upbeat torsional nystagmus in stroke. And because of these nuances associated with the kind of subtleties of differentiating one problem from another, it's fairly easy for us who do nothing else other than dizziness all day to recognize this stuff. It's sort of what we do, it's our job. And there's no necessary expectation that everybody else would know how to do this, but it's something that we can provide help with when people need it. Here's an example of our TELE-DIZZY successes to date, shown in our program. The diagnostic yields of specific vestibular diagnoses in stroke are way up. Non-diagnoses are cut in half. Imaging is way down. We're not just trading CTs for MRIs. The overall imaging is down. The MRIs are held stable. And knock on wood, we have yet to have any cases that returned within 30 days with a stroke after being sent home by our service. Here's fresh, hot off the presses, our AVERT clinical trial diagnostic accuracy that will be presented next week at the BENIGN Society in Madrid. And that this is a sneak peek preview, but this is a prospective phase 2 randomized trial in which we did something very similar. We put video recording devices on people's eye movements, and then we had experts diagnose them independently of the clinical team. And what you can see is significant increases in overall diagnostic accuracy, 246%, and for BPPV in particular, 651%, et cetera. So you can see there's a big gap, and ultimately this boils down to the experts don't have anything else to do but diagnose these dizzy patients. And so in general, it's not surprising that they would be good at it or better at it than the average physician that was seeing these patients who hasn't received any training in these areas. So what are the key takeaways? Most common, most catastrophic, and most costly of medical errors, diagnostic errors. Just 15 diseases account for more than 50% of the serious harms from diagnostic error, making them key targets for error reduction strategies. Neurologic misdiagnosis is frequent, and leading causes of serious harms are strokes, meningitis, and spinal abscess. Bedside exams are often inadequate. And finally, remote specialty consultation programs for clinical symptoms at risk for misdiagnosis, such as TELE-DIZZY, can immediately contribute to diagnostic excellence. And I thank you very much for your attention. Sorry for taking a little longer than was planned, but we've still got 14 or 15 minutes, I think, for questions and answers. I'll stop sharing.
Thank you very much, David, for a great overview of your work and of the potential for accessing expertise for safer diagnosis. I might throw the floor open for questions. So if people would like to unmute themselves, and if they have any questions for either David or Lachlan, if they could unmute themselves and just directly ask. Shaman, yeah.
Thanks, Carmel. Thanks, David. Great presentation. And Carmel, the bundles that we've been looking at, I've been, been waiting for this for a long time. I think there are a couple of questions that I've got. One is the perennial, we work in divulge governments, divulge systems in Victoria. And that seems to be one of the biggest challenges where a bundles actually, the consistency of the bundle and the implementation of those bundles between health services will differ, and how would we actually approach that? Probably more a question towards safer care. And the second, are we at a point now where we can start using technology to also assist us in managing a component of risk? So really looking at the component of AI, where you actually can use it within an EMR, that you can actually identify that this might be the subtleties which are coming through, but we should have enough data that I would think, population data, that we could start picking up subtleties using AI to actually do an element of machine learning rather than completely being reliant on the clinician. And I think the RECG is an example of that. It's that subtleties, but to be able to do that element of learning, but from a documentation, examination findings, the question is, are we at a point that we should start using and trusting AI?
David, I'll pass that to you.
Well, I'll take the second half of the question, then I'll turf the first half back in somebody else's direction who can think about it. So it's a great question. There's generally, obviously, this sort of long-range hope that artificial intelligence, machine learning will eventually help us all, right? It will help us scale these answers. It will help us get to the right diagnosis. And companies like IBM, Watson, and others have tried to make this move where we currently stand, but perhaps prematurely, because the process of doing machine learning is very advanced at this point. But the data sources on which machine learning is done are very rudimentary. And this is where the answer to your question, I think, is no. That is, the data sources that one would need in order to train artificial intelligence systems to recognize these clinical findings do not exist. So what we tend to do with AI and machine learning, at least those who are proficient in the area and are kind of seeking to push the boundaries, they find the most reliable data sources they can, or if they're really not thinking, they just take the biggest data sources they can. And they make the assumption that big data is sufficient. In other words, they make a simplifying assumption that says there's no bias in the data, and whatever noise there is random. And that turns out to be false. And in addition to that being false, you have a problem that not all of the diagnostic information is relevant. It's like the story of the drunk man coming out of the bar, and his friend comes and sees him and he's crawling around the ground. He says, "What's going on?" He says, "I lost my keys, come help me." His friend says, "Where'd you lose your keys?" He says, "I lost them over there." He says, "Well, why are you looking here?" He says, "The light's better." And that's what we're doing with AI right now, right? The light's better around lab tests. The light's better around people's risk factors. The light's better around people's even their demographics or their social determinants of health. And then, but the problem is, if the relevant diagnostic information is in their eye movements or their clinical features, then you can look all you want under the lamp for the keys, but the keys are somewhere else. And so I think we have to mature better data sets before we can take that step. It's our intention. And we have we've already got people working on artificial intelligence to be able to help scale these things, to limit the need for individual experts and allow more of this to happen in a computer processing sense. But ultimately, I think we have to have very well curated data sets before we get there. And that's going to be decades away.
Sharman, regarding your question that was more towards Safer Care Victoria about how you would implement the bundles, I'll have a go at that. Look, my idea would be that it would look something like the anaphylaxis Safer Care Victoria guideline, which incorporates diagnostic features as well as treatment, and which has been implemented statewide. So I think it's possible with these bundles, obviously informed by neurology expertise. Lachlan, yes.
I actually have a question for David. With the AVERT trial and your results there, which really look quite fantastic, have you also looked into, or is it on your radar, the impact on patient flow or occupancy or that kind of thing of getting these patients right and perhaps not having the same reliance on imaging or the time, and maybe not needing to move a patient to a tertiary centre, those kind of factors?
So we have, the answer is yes, but not as much as we need to. The short version is we believe that it speeds things through the system for a number of reasons. I don't have data on the notion of whether it prevents unnecessary referrals, because as yet, the programs that we've implemented have been at places that are themselves referral centers. So I can't be 100% sure about that, but in fact, that's the next wave, that we're working with rural hospitals on a program to try to, because they have this problem. They have a very legitimate problem, which is that if they need an MRI, they have to send the patient transported, 25 miles or whatever more to get to an academic place from West Virginia, where there isn't a scanner, to Pennsylvania and Pittsburgh, where they can get an MRI scan. It's a real hassle for the healthcare system. It's expensive. It's difficult for the patient. It puts the patient at additional potential risk, and so on and so forth. It's better if they can figure that out remotely. I will say that just based on the anecdotes that we've seen, it is by far much faster to evaluate these patients at the bedside. What used to happen in our ED when we were just starting the service was that we would get a call after everything else had been done. So we said, look, just call us at the beginning. If you think this might be a patient you would image, this might be a patient you would call a neuroconsult. It's not just an obvious urinary tract infection or orthostatic hypotension case, but you think it's either a brain or ear thing, and you're going to have to go down that diagnostic road. Just call us instead. We'll take care of it. So initially they didn't call us. They would wait until after they had done all the usual stuff. They had done the CT scan and the MRI scan and the neurology consult, and then they were waiting for a bed, and then they would call us. But after a few of those, we went down, did the testing, and in 5 minutes diagnosed benign positional vertigo and sent the patient home after they'd been there for 12 hours. They started calling us earlier and earlier because they realized that we were going to help them, not hurt them. And I think that's the critical piece, is designing systems where the expertise that people have to offer as specialists can be an aid to people in the emergency department rather than a hindrance of some kind or other. And if we can create systems that make it liquid and easy to do this, it's amazing how fast it can be. I will tell you a story, and I don't think this was told to me recently by a wonderful couple from India, the Bandaris, who have constructed an entire system of remote vertigo evaluation in the country of India. They have 150 clinics. And in a matter of just a few minutes, each patient is triaged and assessed by both a neurologist and an ENT, all remotely. They have sort of end-to-end control. It's not emergency department based, it's clinic based, but they have a technician and a set of gear in each clinic, and then just a central architecture for evaluating those patients. And it literally just takes them a few minutes for each case, and they are able to see enormous numbers of people. I mean, 2,500 people a month with just 6 clinicians. So I do think that it's feasible to do this both efficiently and effectively, but it does require that people be willing to think outside the box, be willing to be thinking along the lines of quantified physical diagnosis, which I think is something that people started to think about during COVID in a way that they never thought about before. Most of them never thought about before. But it's going to take a change to the way we practice medicine to really make that a reality.
Fantastic, thank you.
Thanks, David. David, listening to you, I feel this sense of urgency about the problem of dizziness in the emergency department. We feel like we need to know everything and do everything in ED, and we can't. We need to sort of reach out to experts and, as you say, design systems. But I'm wondering, you know, what you would imagine might work in Victoria, for example, perhaps a more low-tech solution, but with some tech to make something like this work, because it sounds like every day, it sounds to me like almost every dizzy patient needs to be discussed with an expert.
So the key is this: at the end of the day, if you're going to evaluate dizzy patients well, you have to be able to see the eye movement. So anything that you can do that makes it possible to see the eye movements makes it possible. It doesn't have to be a video-oculography system that's, you know, FDA approved and sold on the market for $30,000 or whatever the number is. It can be a mobile phone. Most people's mobile phones take very high resolution videos. We have a separate program where we've actually got it set up so that people can, this in our case is not intended for ED use so much as for outpatient patient in their homes use. But as part of the COVID process, we realized that patients had stopped coming to the emergency department with dizziness. They were afraid to come to the ED. And so what we did was we instituted a program where they could essentially email us using an app that helped them record their own eye movements and ship them to us for the purposes of remote interpretation. Now, in the US, things like that tend to get bogged down in all sorts of arguments about data transfers and HIPAA and other stuff, which has made it more cumbersome than it might have been and less helpful to patients. But I think in a country like Australia, where you have more common sense about the way you manage your healthcare system, I'll bet you could do that. And we do this routinely all the time. I can't tell you how many friends, family, or other physicians I have diagnosed literally over FaceTime. Not that I have any stock in Apple, but the conceptually, if you can get a good look at the eye movements, you can usually diagnose the patient remotely. So anything you can do to construct that. The problem is that you can't just use a real-time web camera on most systems because the frame rate resolution is too low. So the actual, you have to be able to convey a high enough resolution video to the remote expert that they can actually see the natural appearance of the eye movements. What you saw even today over the teaching thing probably didn't look the same as it did on my screen. And that difference is the difference between getting the diagnosis right and wrong. We've actually just written a paper about that, about the sort of parameterization of what's required in order to do telemedicine for dizzy patients in terms of frame rates and similar, and kind of where the technology is constrained. But it doesn't have to be expensive. And honestly, mobile phones are very strong pieces of equipment that almost everybody has access to. But then you have to construct systems of care that allow that to happen, that you allow people to use mobile phones for that purpose in a more systematic and robust way than we currently generally do. Like, it's sort of done as one-offs now. You could probably still do that, but it's harder to scale that up in a robust, you know, kind of bundles of care sort of way if everybody's using a different mobile phone and a different platform and a WhatsApp. But maybe you can. It depends on your regulatory environment. Thank
you, David. Look, I'm conscious that we're right on time. So if we don't have any more questions, we might close there. I just wanted to thank both Lachlan and David for fantastic presentations. I think these types of collaboration to improve diagnosis are fantastic. So on behalf of the webinar, Supriya, oh, that's some clapping. Sorry, I thought that was a question, but some clapping. Thank you. I want to apologize that my slides weren't advancing. That was a good example of failed technology, but We will attach them to the final recording. And I just wanted to thank VMIA, ANZA-SIDM and Australasian College for Emergency Medicine, Safer Care Victoria for this great collaboration together. Thank you again, David and Lachlan, and sleep well over there, David.
My pleasure. Thanks very much. Good to see everyone. Take care.
Thanks, David.
Thanks.
Bye-bye.
Thanks, Lachlan.